Hello, and welcome to the Princeton Spine Joint Center podcast. My name is Scott Curtis. I'm the Director of Sports Medicine here for the group. I just had a wonderful conversation with Lisa Baptis. She is a physical therapist at Penn Medicine Princeton Health Hospital, and she specializes and has been trained in the Meeks Method. We talked about osteoporosis, specifically what exactly is osteoporosis and why it's such an important topic, being that it's so prevalent in the population, and if not treated appropriately, it could cause severe pain and even fractures. So I really hope you enjoy this conversation about osteoporosis. Hello, and welcome to the Princeton Spine and Joint Center podcast. My name is Scott Curtis. I'm the Sports Medicine Director here for the group. I'm joined today by Lisa Baptis, a physical therapist affiliated with Penn Medicine at Princeton Health. And today we're going to be talking about osteoporosis and different things about osteoporosis, specifically lifestyle modifications, physical therapy, and different kind of treatment options for osteoporosis. Lisa, thank you for joining us on the podcast today.
Thank you for having me.
So before we get into kind of the nuts and bolts of osteoporosis and what it is and what are we here to talk about, just tell us and the audience a little bit about yourself and how you kind of came through as a physical therapist who has a passion for osteoporosis.
Great. Well, I guess I got started, I went to my undergrad at Rutgers University, and I wasn't quite sure what I wanted to do. I started in the sciences and originally thought I would go into social work. Mm-hmm. I knew I wanted to do something helping people. And then fortunately, I was put as a volunteer at the hospital in the physical therapy department and just absolutely loved it. And then I went to Temple University, got my degree in physical therapy. And I've been fortunate enough to be able to practice in a variety of settings. I've done outpatient, I've done acute rehab, I've done corporate fitness, and now I'm settled into outpatient, and I do orthopedics as well as vestibular therapy, concussion treatment, and now trained in osteoporosis as well.
Yeah, and that's what we're here to talk about today, because I think it's a very important subject. You and I both have a lot of patients who have been diagnosed or are concerned about osteoporosis. Mm-hmm. And we want to kind of get out to the viewers and the listeners, what osteoporosis is, maybe dispel a few myths that might be affiliated with it. So what exactly is osteoporosis, and why is it such a big deal?
Yeah, I think you're right. This is something that is a big issue, and I think it's really important that we start addressing it in our healthcare. So osteoporosis literally means porous bone. Mm-hmm. And what happens as we age, we don't lay down as much bone as we were doing when we were younger. And so the bones actually start to get brittle, mm-hmm. and it puts us at high risk for fracture. Mm-hmm. And so I think the biggest risk is when we fracture, that causes a lot of problems and can lead to mortality.
Yeah. Yeah, and that's really what, it's a great explanation. So basically there's kind of a contrast between two cells in the body, one that builds bones, mm-hmm. and then one that kind of degrades it so that it could produce some of the minerals and ions needed within our bloodstream for cellular function. And when we're younger, the osteoblasts or the bone building cells are very prevalent, building up the bones. And then as we get older and different hormones change as we get older, there's less bone building and more bone remodeling. And osteoporosis itself is kind of on the spectrum of bone, density loss. But I think one of the big things that I want to get to the viewers and listeners is osteoporosis doesn't have any symptoms, right? You don't know if you have osteoporosis. It's not like you have pain associated with osteoporosis. But osteoporosis itself can lead to fractures and lead to issues that then becomes painful. So what do you kind of talk to patients about when you're educating about osteoporosis?
Well, I think it's kind of like a three-pronged approach. We think about exercise, medication, and nutrition. My emphasis, of course, would be exercise, maintaining adequate posture, and body alignment is really important. Yeah. And, also educating them to prevention, actually, and the way that they move is really important.
So there's definitely, not everybody will develop osteoporosis. There's definitely risk factors for it. What are some of the risk factors that you see, and what are some things that are common things that may not necessarily be as risk factors, but we could kind of intervene on earlier on to prevent risk factors from occurring?
So I think people think that osteoporosis is really just for older people, but in reality, I mean, it can really happen at any age to any person, any ethnicity. So I think educating people about that is really important. And in fact, you could even start educating people really young, because what they're finding right now is that even younger people are not developing their peak bone density as a youth person. So because I think people are sitting a lot longer these days,
Sure.
and they're not aware of their posture. They're not getting enough exercise.
Yeah.
So what happens is if you're not developing your peak bone density as a young person, then you're actually at higher risk when you get older to develop osteoporosis, again at risk for fracture. So
Yeah. When is peak bone density kind of seen typically?
So you reach your peak bone density at about age 30, but the maximum, usually they see it between 18 and 20 years old.
Okay.
And so what they're finding that they're really not getting to that point where they should. So
Yeah, and certainly, there's a lot of issues, obviously, with how sedentary we are, this day and age, especially with, cell phones and computers, and, we're constantly looking forward, and we all develop bad postural habits and that tech neck. But that could definitely not only play a role on things now, but things in the future, like osteoporosis, developing it later on in life. And so I think one of the big myths, as you said, is age. Osteoporosis is most commonly seen in older individuals, particularly older women, after menopause. And the reason why that is because estrogen really helps protect the bones, right? It helps kind of decrease bony remodeling. And then as women enter menopause or even afterwards, they lose some of that estrogen, and then their bones start to remodel further and further. Which is why one of the mainstay recommendations for screening process from a primary care perspective is after the age of 65 to have what's called a DEXA scan, which looks at the bone density. And based on the DEXA scan, there's a couple of markers. It'll be normal, and as the bone gets less and less dense, it'll enter what's called osteopenia, which is not osteoporosis. It's kind of the beginning part of bone density loss, and that can, if untreated, lead to osteoporosis. So do you kind of, in terms of your approach in your counseling, do you differentiate between osteopenia or osteoporosis?
not really, because I think even people with osteopenia, the exercise is super important for. And it's actually important that they get it earlier on than later.
Right.
Because then they can start to modify their lifestyle.
Yeah.
They can start to, get the proper nutrition, proper exercise. So I think actually getting them earlier is even better
Absolutely.
than waiting until they're actually diagnosed with osteoporosis.
Yeah, I think that's so true. The reason why we make, as physicians, the distinction between osteopenia and osteoporosis is because when you cross over into that line of osteoporosis, that's when you start pharmacologic therapy.
Yeah.
And there's a lot of different medications out there. They're coming up with new ones. The old ones, or the ones that have been longer around, typically the bisphosphonates, have been around and work for some patients. There's a lot of associated side effects that concern people, so they've come up with different types of injectable ones. And I often will defer to the primary care doctor, or rheumatologist, or an endocrinologist to counsel their patients about that. But that's really why it's important to distinguish osteopenia and osteoporosis. But I 100% agree with you that if we can start doing non-pharmacologic therapy, counseling, exercise, postural education in the osteopenia range, it could hopefully prevent going into osteoporosis. A little bit of prevention is worth a whole lot more than a lot of treatment. So I think it's really, really helpful. So let's kind of talk about what happens when you see a patient for the first time. Let's say I'm a primary care doctor, or even, in our practice, I'm concerned, or the patient's concerned about osteopenia, osteoporosis, and I refer to you. How do you kind of first evaluate the patient, and what's your kind of approach?
Okay, well, I have training in what we call the Meeks Method, which is a very comprehensive program developed specifically for osteoporosis. So when somebody comes to me, we'd first start with like a screening to sort of determine their risk factors, ones that are modifiable and ones that are not modifiable.
Okay.
We would actually do a posture screen. We use something called a Redco score, which is something we do initially, and then again something that we could redo later on to see how well their posture has progressed.
Okay.
We also do a height measurement too. Then we would do just general like range of motion, strength testing, sensory testing, evaluate their pain measure. We'd also do a balance assessment to see what at risk they are for falling, which you know is very important,
Yeah.
especially in the elderly population. And then we'd also test like flexibility.
Okay.
Because as we have poor posture, a lot of muscle changes happen. We develop some weakness or some tightness, so we
Sure.
can really make the program specific for that individual, where they're at. What else? I think that's about it. And so based on all those things, we would then design a program specifically for them.
Okay. How long are these programs typically designed for?
I think depending on where they fall, like if they're relatively healthy and young and they're just maybe firstly diagnosed and they, you know, they're pretty active, they might need maybe 6 sessions, which would be basically the screening, finding out exactly what their specific needs are, and then starting with the program specifically goes in levels. So we'd start at the lowest level, starting with postural re-education. Then we'd spend a session talking about like training, like how do you do things correctly when you're getting in and out of the car, when you're getting in and out of bed, when you have to lift things. And then once more advanced exercises using maybe bands or a foam roller, and then sort of training them to like follow that through in the gym and what things are safe for them to do if they're going to do yoga or if they're going to work out with weights.
Right.
So, I mean, a lot of people think, you know, oh, I just need to do weight-bearing exercises.
Yeah,
but
that's what we're taught in medical
that's
school,
what we're taught.
right?
But it's really a lot more than that, because say somebody goes to the gym and they think, oh, if I just lift weights, I'll be fine.
Right.
But if they're like not standing in the right alignment lifting weights,
Yeah.
or they're doing exercises, they think, I want to do abdominal strengthening. They do certain sit-ups or certain exercises that are actually
They can make it worse.
They can make themselves higher risk for compression.
Absolutely,
in their spine. So it's really important that they really learn the right way to do things and to align themselves correctly so that they can get the maximum benefit and they can protect themselves from injuring themselves at the gym.
Absolutely. I think, again, it all goes back to education. You know, unfortunately, I see a lot of patients who develop compression fractures. They come in with back pain. Maybe they've been diagnosed with osteoporosis and chose not to have treatment, or they didn't know, you know, because they're younger than 65, that they have risk factors for osteoporosis. And they're working out at the gym, they do a sit-up and they get an L2 compression fracture. Or, you know, they had a fall and they fracture their hip and now they're found to have osteoporosis, osteopenia. So you talk about some of the risk factors. What are some of these risk factors that we can identify and potentially change some of the modifiable ones?
So I think nutrition, posture, change. Like when you teach them.
Well, let's talk about them individually. So what about nutrition is kind of an issue with osteoporosis?
Right. I think like educating people. Well, I'm not a nutritionist, so I would definitely just generally refer them to a nutritionist, but making sure they're getting enough calcium, making sure they're not drinking beverages like soda or seltzer that can affect their calcium intake, making sure they're getting enough correct food in their diet, like healthy green vegetables, and they're drinking plenty of fluids, correct fluids, water. So that kind of thing, making sure those are something that we can change.
Yeah, absolutely.
And we can change their exercise habits, and we can certainly change the way they align their body.
Cool.
So I think those are the main things that we can address.
Yeah, absolutely. I mean, and look, I always tell patients that there's things that we can do something about in terms of risk factors. There's things that we can't do. I'm sure there's some sort of genetic link, you know, for osteoporosis. Whether that's really been identified or not, you know, what gene type, it doesn't matter. There's not much I'm going to be able to do or that you're going to be able to do about it. But things like nutrition, you know, or, you know, talking about excessive alcohol use, which could lead to osteoporosis, smoking. These are all things that we could at least counsel on or identify and say, okay, these are your risk factors. Let's try to fix these. We can't do much about those, but we'll keep that in the back of our mind.
Sure.
So identifying the risk factors are very important. We talked about the nutrition, exercise habits. So what kind of exercises? We talked about how weight-bearing exercises, things like walking and running can be beneficial. But what other exercises might be beneficial for the patient?
I'm glad you asked that because in the Meeks Method, we do what we call site-specific exercises, which are exercises of specific muscles that are very close to the spine.
Okay.
So we develop those deeper muscles that really help support the spine, and we also do exercises to try to elongate the spine. So that's kind of where we start. And we do exercises that will help for decompression of the spine.
Okay.
So those are the first things that we teach them. And then we do a lot of upper back exercises for postural training. So we do a lot of strengthening of the upper back, a lot of stretching exercises. We do a lot of exercises with the foam roller to really get a little bit more pressure to the spine to really develop a little more tensile strength to the anterior part of the spine. So, and then we graduate from there. So then we'd start in like the least compressive position, which would be on your back.
Okay.
And then we'd move to on your belly. Then we'd start like in hands and knees, and then we'd go to standing, and then the last would be sitting, making sure people, if they are going to exercise in sitting,
Right.
that they are exercising in the right position.
Yeah, absolutely. And you have to transition that to, a realistic out of physical therapy type
Correct.
model, right?
Yeah.
You can't just, a lot of patients will feel great during physical therapy, but they won't incorporate it to their regular life, or they won't incorporate it into the gym. And then they basically lose everything they've gained while working with you.
True.
I think, so it sounds like at least one of the main differences between what you are doing with compared to traditional physical therapy is usually with traditional physical therapy, there's a painful problem, right? If I'm sending somebody for a shoulder rehab, they typically will have pain or some sort of, weakness or dysfunction that you're tracking throughout the entire course. How do you do that with somebody who never had any symptoms to begin with? Because like we said, osteoporosis doesn't present with symptoms. How do you kind of gauge progress and know when somebody's ready to go through the Meeks Method to a different point?
So that's really important. So when people come in and they really don't necessarily have pain, I think that's where the education component comes in. If we explain to them like why we need to do these exercises and how helpful that'll be in the future for them. I think if you can get that buy-in so that they can understand exactly why they're doing this and actually talk to them about making a lifestyle change versus just, doing this for this one session that you're here.
Right.
And then once they've learned that first set of exercises, the more site-specific exercises, and they know how to do it correctly, and I've observed them, then I would increase the resistance. And I'd add more resistive stuff with bands and rollers, and then I would actually go into the gym and show them exercises they can do, make sure that their form is correct. And that's how I would transition them.
Cool.
Yeah.
Yeah, no, that's great. And, one of the frustrating things, at least from a medical standpoint, that I deal with osteoporosis is patients are coming to see me for it too late, right? It's similar to, in primary care, we treat blood pressure, right? Or diabetes or cholesterol. A lot of times those patients won't have any symptoms whatsoever. And it's just on a routine screening that we pick up high blood pressure. Same thing, it's a routine DEXA screening. We pick up osteoporosis. Patient has no symptoms. So they don't want to take their medication. Why are they taking a pill or an injection that actually might make them feel worse if they never had symptoms to begin with? But it's super important to intervene early, whether it's with medication or early intervention like what you're doing with the Meeks Method, to prevent serious problems down the line. It's very, very difficult to get everybody to buy into that, right? How do you kind of encourage patients when they're not really having any issues to begin with? Any tips?
I think people, as we move towards prevention, hopefully, I think even this may be something good for like primary doctors or to like let the patient know there's something available to them that they can do. So I think sometimes, you hear osteoporosis and they think, oh, I just have to do weight-bearing exercises. But I think if they absolutely know that there's something else that they can do, hopefully those people will say, you know what, I'm gonna just like trying to promote exercise, which is very hard for some people to follow through with, but making it become a habit and that kind of thing. I think just maybe starting early on and every time they come for that physical saying, there's something you can do about it. And I maybe some people don't even know that this method is available to them. So I think just kind of getting the word out that, there's really something that can be done early on and it's going to prevent you from really having a lot of problems later on in life.
Yeah, I think it's really, really important to talk about this. And, we're all super busy as practitioners. We may not have enough time to really sit down and counsel patients, but I think it's so helpful to provide education. And like you said, assure them that there is something that we could do earlier on. But unfortunately, that doesn't always get through. And we start seeing patients who wait until there's a fracture and there's a problem. They're in severe pain. And now we're kind of fighting an uphill battle, right? Because it's now on my end to kind of get their pain under control. Right. And now on your end to get them past where they are. They're not in the prevention phase. They're now in the secondary prevention phase where something has already happened. So it's sometimes frustrating. But it's really, really important to continue hammering that education down and try to do the best that we can.
I think one benefit for me is sometimes I will see people, and I know that that's in their history that they have osteoporosis. So I always try to take advantage of that opportunity and say, there's a method that we use actually here to help kind of nip that in the bud and start preventing things from getting worse. And, some people are really receptive to that. I just think that their awareness is not out there just yet.
Yeah, it's hard because at the end of the day, when you look at things that are, in terms of primary care medicine, what are preventable, screening tests that we do on a regular basis, osteoporosis in theory shouldn't be life-threatening in any way, right?
Right.
At least to the layperson, compared to, let's say, screening for breast cancer or colon cancer, that potentially could be life-threatening. But that's not necessarily true because we know that individuals, especially older women who develop a hip fracture or a fall, they have a higher morbidity mortality than the general population if there's a fracture. So it's really important to intervene on that earlier and intervene on balance issues and kind of fall prevention. How much, because you mentioned it before, how much of your therapy sessions or education is about fall prevention?
Well, we do a fall screening,
Okay.
and then we will do different balance tests to kind of see where they fall in that. But I usually incorporate that definitely into their treatment, giving them some balance exercises to do, kind of see where they're at, not just statically, but dynamically.
Okay.
We do a lot of balance training on different surfaces and kind of seeing if they can maintain. But it's definitely something that they have to continue with.
Sure.
As you know, if they don't continue with it, it will decline. So it's also educating them like, okay, it's good that you're doing it now, but something that you need to continue with. Even if it's just you do it, once a day while you're brushing your teeth, or you're trying to incorporate these things as, kind of looking at things as a lifetime change, not just that moment that they're in PT. I think that's the struggle for a lot of healthcare is that, they may be on board for a little bit, but then, as we all do, kind of start straying from our...
Yeah, we get tired and lazy or bored with some of the exercise, or we forget, or life happens. And I totally understand that. And a lot of times I'll tell patients, look, why don't you go back to Lisa or go back to the therapist? Let's get a refresher course, get you back on board. I often will tell patients, the worst thing that could happen is a fall. Especially if you're alone. I have tons of patients on blood thinners, that really could be in bad shape if they fall. Whether they have osteoporosis or not, any kind of fall, even a low impact one, could potentially be an issue for our older population, especially, but anybody really. So it's something that I often will talk about, balance issues, fall precautions, making sure you're steady on your feet before getting up. So I think it's definitely something very helpful. So we talked a lot about osteoporosis. We talked a lot about your screening methods, risk factors, treatment, education. Is there anything else that you think maybe the listener or the viewer should know about?
Yeah, I think, it's never too late, whether you're young and healthy and you just got diagnosed with osteopenia or even maybe just low bone density, or you have had falls and fractures. It's never too late to start to make those changes, and that there is definitely something that you can do about it. And you should start as soon as you can.
Yeah, I think that's a great message. And I really appreciate you coming by and talking with us about osteoporosis. And hopefully we can get this out to our patients and they find it interesting and they learn from it.
Thank you for having me.
Yeah, thanks.
Thank you.